Hey everyone, welcome to my channel. My name is Steven. I am a board-certified physician assistant with experience in emergency medicine, urgent care, and family practice. Today we'll be discussing over a few key points about coronavirus, specifically COVID-19. Before we get started, it is important to know that our understanding of COVID-19 is still incomplete and there is still ongoing research. Without further ado, let's get started. Coronaviruses is a family of viruses that affects both humans and animals. Its name is derived from its crown-like appearance under microscopy. Some of the more well-known coronaviruses that you may be aware of is the MERS outbreak of 2012, as well as the SARS epidemic of 2002. On February 11th of this year, the World Health Organization designated the disease COVID-19 as coronavirus 2019 and the virus that causes it as SARS-CoV-2, severe acute respiratory syndrome coronavirus 2. Where did COVID-19 come from? From our current understanding, COVID-19 came from the wet markets of China. From previous genome sequencing of bad coronaviruses, there does show a resemblance between the SARS virus of 2002 and COVID-19. A lot of times bats serve as a reservoir for a different type of virus, and they're able to pass disease to the susceptible host. There are many diagnostic tests for the detection of COVID-19. I'm specifically going to focus on the molecular test and the antibody test. The molecular test plays a very crucial role in determining active disease as well as monitoring the spread of disease. The advantage that this test plays over the antibody test is that it can detect active disease 2 days on average before an individual becomes symptomatic, up to a few weeks after an individual has gotten sick. Whereas antibodies don't usually develop a few days up to 2 weeks after an individual has gotten sick. The second test we're going to talk about is the antibody test. The antibody test determines whether or not an individual is exposed to the virus. It also determines the immune response an individual has had to the virus. An antibody is a protein of the body's immune system that binds onto the antigen of a foreign invader, such as a virus or bacteria, and then neutralizes it. If you guys take a look at this graph, it gives a rough estimate of the time it takes before an individual develops an antibody response to COVID-19. One piece of literature that I reviewed took 338 COVID-19 positive patients with different severities of illness. On average, IgM developed during the initial week of infection, followed by a peak at 2 weeks and a drop, whereas IgG developed 1 to 2 weeks into infection, peaking around 3 weeks and maintaining those levels. As I previously mentioned, antibody testing is useful in later stages of illness and can determine if somebody was previously exposed to COVID-19. Here's a chart that outlines some of the possibilities that can result from antibody testing. There are, of course, more specifics to the interpretation of these results, but this is just a brief outline. For example, let's talk about the first row. If IgM is negative and IgG is negative, that does not necessarily mean you weren't exposed to COVID-19. Again, it does take time for the body to muster an immune response, and you may be in the incubation phase where you were not exposed, and molecular testing may be an option to check for these possibilities. A lot of you may ask, if you developed antibodies to SARS-CoV-2, does that mean you have immunity? Unfortunately, there's not enough research out there to determine long-term immunity to SARS-CoV-2. Our current understanding of COVID-19 immunity is based on our knowledge of previous coronavirus infections. For example, the SARS epidemic of 2002, the average time frame of immunity was about 2 years, whereas other coronavirus outbreaks would only last for a few months. The duration of immunity and antibody response may also be related to the severity of symptoms. where a person with mild symptoms may develop less of an antibody response. Coronavirus is primarily spread through close contact. It's difficult for us to obtain an accurate sample of the virus in the environment because when we cough, the virus particles is spread not uniformly into the surfaces and into the environment. Some of our understanding of the transmission of COVID-19 comes from our previous experience with the SARS epidemic of 2002. There was a case study of 624 healthcare workers in Toronto, Canada, and this study showed that the likely mode of transmission was through droplets as well as close contact. If you're out in the public, current CDC guidelines recommends that you are approximately 6 feet away from another individual to reduce the risk of exposure. It is also important to know that when COVID-19 is aerosolized, it can stay in the air for approximately 3 hours on average. And it also can stay on surfaces such as metal, glass, or plastic for a few days, up to 9 days on average. Individuals who are at higher risk of developing complications to COVID-19 include those who are at a higher age, greater than the age of 65, those who have history of heart disease, those with history of hypertension, liver disease, immunocompromised, or history of lung issues such as asthma or COPD. Some common symptoms of COVID-19 include cough, sore throat, low-grade fever, headache, body aches, diarrhea. More concerning signs and symptoms include chest pain, shortness of breath, blue-tinged lips or mouth. As disease progresses, patients may develop sepsis or acute respiratory distress syndrome. Trajectory of illness ranges anywhere from 2 to 8 days with mild symptoms and may progress into critical disease beyond 1 week. Usually, the majority of the population is able to fight off infection. However, even young, healthy individuals may develop alarming symptoms, and I've personally seen this firsthand managing patients in the hospital. Recently, there have been many cases of pediatric patients developing a process called multi-inflammatory syndrome in children, MISC. In pediatric patients with MISC, they present with fever, laboratory-confirmed inflammation, and multi-system organ involvement. Some of the presenting symptoms manifest similarly to an unknown vasculitis called Kawasaki's disease. Our current understanding of MISC is incomplete, but there's a lot of speculation that the syndrome is associated with COVID-19. I attached a morbidity and mortality report in the description box below. Some of the more common and effective ways of reducing the risk of catching COVID-19. Some of these include, of course, practicing good hand hygiene, covering your face and mouth with your sleeves when you sneeze, cleaning and disinfecting commonly touched surface areas, and of course, practicing safe social distancing. Before we get started, first we have to understand the role ACE2 plays in the cellular molecular function in our bodies. ACE2 stands for angiotensin converting enzyme 2. It is an enzyme that is attached to the cell membranes throughout organs in our bodies. As a lot of you may know, one of the primary functions that ACE2 performs is the regulation of our blood pressure in the RAAS cascade, or the renin-angiotensin-aldosterone system. ACE2 is located throughout the organ systems, including GI tract, heart, lungs, blood vessels, nose, mouth. SARS-CoV-2 has an affinity for the ACE2 enzyme, and this may account for the multi-organ involvement and the symptoms that present with COVID-19 infection, such as diarrhea, shortness of breath, hypoxia, abdominal pain, and the abnormal serological markers associated with the disease. Patients who I have seen with complications to COVID-19 usually present with ARDS, Acute Respiratory Distress Syndrome, and hypoxia, which is likely due to injury of the lungs. Here is an image of the lungs. Air passes down the trachea, bronchi, bronchioles, and lastly to the alveoli, where carbon dioxide is exchanged for oxygen and vice versa. This is where gas exchange occurs. This is also where SARS-CoV-2 plays a role by binding onto the ACE2 enzyme receptors of the type 2 pneumocytes. Once inside the cell, COVID RNA uses the host system to replicate proteins and more of itself. As I previously mentioned, ACE2 plays a role in the regulation of blood pressure. When the body senses a drop in blood volume or vasodilation, the kidneys release renin. It converts an inactive protein from the liver, angiotensinogen, to angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 by the enzyme ACE that is released from the lungs, converting it to angiotensin 2. Angiotensin 2 binds and tells the adrenals to release aldosterone to help with decreased blood pressure. However, we are focused on the mechanism of COVID-19, so we're going to discuss that instead. If you take a look, angiotensin 2 binds onto the AT1 receptors that promotes vasoconstriction, prothrombosis, and pro-inflammatory changes in the body. ACE2 opposes this pro-inflammatory effect of angiotensin 2 by converting it to angiotensin 1 through 7, which subsequently binds onto MAS receptors, causing vasodilation, anti-inflammatory, and antithrombotic changes. But if COVID decreases the expression of H2, then you won't be able to convert to angiotensin 1 through 7, and the body will be in a pro-inflammatory state. Because of this, the lungs become more inflamed, and the body is already in a heightened state of inflammation due to the cytokine storm, which is a hyperactive immune response from the body. This leads to increased lung inflammation, fluid, fibrosis, leading to hypoxia and ARDS. If you take a look, and I've seen many cases myself, critical patients with COVID often develop what we call ground glass opacities on CT imaging of the chest. And as I previously mentioned, because ACE2 is located throughout our organ systems, we tend to see patients coming in with elevated inflammatory markers like CRP and LDH, and there are hypothetical mechanisms that COVID-19 causes endothelial injury, myocardial damage, and hence the elevated D-dimer and troponins that we also see in the hospital. So this concludes our video. If you have any questions, feel free to leave a comment below. I did leave links to the articles in the description box, as well as the link to the CDC website. Feel free to refer to the CDC website for up-to-date material on COVID-19. Again, our understanding of COVID-19 is still incomplete, so I do hope to bring out new material as we gain more understanding of COVID-19. If you have any questions, or if you enjoyed this video, feel free to like it, and I do look forward to seeing you guys all soon.